Shalom and welcome again to Seekers of Meaning, the podcast and TV arm of Jewish Sacred Aging. I'm your host, Rabbi Richard Address. Thank you very, very much for joining us today as we attempt to explore some of the issues that impact our communities, our families, and ourselves in this wonderful revolution in longevity. We invite your comments and suggestions to me, Rabbi Address, at jewishsacredaging.com. You can go to the website, jewishsacredaging.com, and check us out on, as well as the Facebook page. And again, we welcome your comments, suggestions, and concerns. One of the issues that all of us in some way, shape, or form are going to be dealing with, or will deal with, has to do with our involvement or entrance into the healthcare system. Let's just say a challenging entrance into what is a variety of mazes and concerns and vocabulary that sometimes can drive us a little crazy. To help us negotiate that and to also really raise some very, very challenging issues as to the current state of our healthcare system, it is with great pleasure that we welcome Michael Connelly, the CEO Emeritus of Mercy Health, and the author of a very, very interesting, challenging, and very, very relevant, recently published book called The Journey's End. The Journey's End, subtitled The Investigation of Death and Dying in Modern America. And it's much more than just a conversation about death and dying. Really, it is a conversation about the American healthcare system. And since our generation and the generation ahead of us is intimately involved in many ways, we thought a perfect opportunity to have this conversation. So, Michael, thank you. Thank you for joining us. Hope you're feeling well. How are you doing?
I'm doing just wonderful and excited to be here.
Thank you very much. Again, congratulations on this book. I'm going to be, for people who may be interested in this, it is an intense book. It's not an easy, light read. Available on, Michael, Amazon as well as bookstores. Is that correct? What motivated you to write this? I mean, I know you come from a career involved with healthcare issues. You're still involved with some of it. What was the motivating factor? What was the thing that pushed you to say, I have to put some of this on paper?
So, I spent my entire career trying to fix healthcare. At least, whatever I could contribute to, try innovations, implement new ways of doing things. And I have to say, by the time I retired, I was feeling it was much worse than it was when I started. And wow. that it just seemed beyond repair. And so I started looking at the reasons why. And initially, some of my focus was on economics and ethics. So I was trying to look at those two elements very intensively. And I discovered that how we care for the elderly is a microcosm for what's wrong with healthcare. And that becomes basically, I had a 5-year journey of research and writing for this book. And so I think the secret to not only improving care for the elderly, but also for reforming healthcare is in the recommendations I make. The other thing that frustrated me is that there are so many books written on end-of-life care. The most famous being Dr. Atul Gawande's Being Mortal.
Right.
Yet none of them, while they do a wonderful job describing the problem, none of them really look at what caused the problem or what solutions there might be to the problem. And so my focus in the book was to diagnose what the real cause of the problems were, and then secondarily to offer recommendations that could be implemented that would address those concerns.
And you do that at the end of the book. I think it's on page 209 is an appendix that really just basically says, okay, here are some implementable, correct solutions, possibilities.
That is correct. I mean, the details of those are described throughout the book, but then they're summarized at the end with definitive recommendations.
You write in this book, quote, The more sophisticated our society becomes, the more we resist death. The more sophisticated our society becomes, the more we resist death. Walk me through what you're talking about.
So I think that you could take it right back to the Enlightenment. And it is that we feel we control. We increasingly assume we control our lives. And we think there's a fix to every health problem. And we expect that you will offer us a fix to every health problem. And then I think the Kool-Aid was bought by the health system. They think they can fix every health problem. And so what I'm thinking about is that we have a lot less success in treating the elderly than any of us think. And what that has resulted in is a tremendous overtreatment of the elderly. And so I've gone into why. Why does that happen? Well, the number one reason is all of us are afraid of dying. I mean, I'm afraid of dying. Everyone is afraid of dying. But you add to that fear the idea that we can somehow stop that from happening. It's a bad combination because it's an illusion. It isn't true that you're going to stop yourself from dying. I often refer to a lot of end-of-life treatment as people almost think like they're going to buy lotto tickets and they think they're going to win. I mean, it has about that high a probability for a lot of things that we do. Then it combines with that fear of death to the fact that nobody wants to talk about it. And therefore, nobody knows what anybody really wants. So I noticed one of the things that you've done, Rabbi, is something at Cedars-Sinai with advanced directives. And it's a very good piece on helping you have a conversation about what you want. And so most people just don't want to have that conversation. Then you have the belief in medicine that healthcare views dying as failure. So when you're getting advice from your doctor is viewing it as what is the thing I can do to save you, not maybe what's the best thing to do for you. And so you've got that. It's a sense of failure by a physician that if they don't treat you, if they don't come up with some next step to take care of you, they're failing. And that leads to overtreatment. And then you add to it the insurance world, which pays for all the expensive stuff, but doesn't pay at all for all of the things that could support you in old age that would actually work a lot better. So you can get transplants, you can get all the time you want in ICU, you can get high-tech ER visits, but you can't get home care. And you can't get basic support to stay at home. And so doctors don't want to talk to you about a natural death. To them, that's not a natural act. And so the system isn't designed to even talk about palliative care or hospice.
We're seeing, and we've had several people on the podcast who are really doing a tremendous amount of work in trying to raise the level of awareness, reduce the fear factor, but also talk about the growing specialization of palliative care. I do some work with a local hospice here in southern New Jersey. One of the recent podcasts we had on, I think about a month ago, was on an end of life doula. There seems to be, and I'm just wondering if you think, my sense is that the baby boom generation wants to exercise more control even over our own death. And so we're a little bit more, yes, we're very afraid of dying. B, we don't want to, but C, we want a lot more control. And so we're a lot more willing to have some of these conversations, although it's not by any stretch of the imagination universal. Because I have sensed in this last decade or so, and maybe the pandemic has something to do with this, a greater willingness to have to at least entertain conversations around this.
So, hospice has a big marketing problem. And for example, most people do not know that your life expectancy is longer in hospice than it is with active treatment. And so the problem is that everybody now knows about hospice, but it doesn't become recommended for patients until all other treatment options have been eliminated. And so the typical length of stay in hospice is 10 days. Whereas in order to have the hospice experience be meaningful, it should be more like 6 months. And so, and that is driven by insurance and economics. Because the hospice benefit has this insane requirement that a doctor needs to certify you're going to die in 6 months. Well, that is just ridiculous because it's clinically impossible to predict death 6 months out. And yet Medicare requires that. And so now we overcome that by having hospice hire doctors that do the certification. But that isn't the problem. The problem is that your caring physician, whatever you're getting cared for, that's the one that has to bring it up. And they're just not going to bring up that you're going to die in 6 months because they still want to try to save you. And so the next problem with hospice is that it doesn't allow you to continue with curative care, meaning any active treatment. You need to literally leave Medicare and join a separate insurance product called hospice. And when you do that, you give up any curative care. Well, that's another reason doctors don't like to recommend it and why patients are more reticent to join until the very, very end. However, there is plenty of evidence to show that if you allowed a patient to have both curative care, in other words, continue with Medicare and beyond the hospice benefit, they actually quickly migrate to the hospice benefit and stop seeking curative care because they see it works much better for them. And as a result, patients have the mental security of having the care, but they end up not using it because they don't really need it or want it at that point, but they still want the right to do it. So that's the problem with hospice. Now, palliative care has even bigger problems. And that is that palliative care doesn't get referrals. In other words, doctors don't call in palliative care. I'll give you a great example. Nephrologist. So let's say a patient goes into kidney failure. The first thing that's going to happen is they're going to call a nephrologist. Well, and they're going to recommend that you go on dialysis. Well, and I'm specifically referring to elderly patients at this point. But actually, for all patients, the average time on dialysis is 1 year. So what you're really doing is postponing your death. And a lot of these dialysis treatments are in ICU or whatever. But they should have a palliative care consult before the nephrologist. And so then the patient more objectively looks at, do I really want to go on dialysis? And they can really more clearly articulate their goals and the family can understand. So palliative care finally is not reimbursed by the system. We have a massive short. There is no outpatient palliative care. And actually palliative care should be part of outpatient care significantly. We should have those conversations, ideally even filling out your advance directive with a palliative care doctor or a nurse palliative care person, rather than going to a lawyer's office. So those are all barriers. And the result is that while hospice is being used more, it's not being used well. And then finally, the problem with hospice is the way we pay for it. Hospice is probably the simplest service in healthcare. There is not a lot of complexity with the care. And we've decided to pay it through our coding system. Our coding system is the number one problem in healthcare. It's way too complicated. And it does two things. One, it distracts caregivers from caring for you because they have to spend all their time meeting the coding rules. And secondly, it is so complicated that it invites fraud. And so that's why the for-profit sector has taken over hospice, because they know how to make money off it by manipulating the coding system.
Michael, and again, we're talking to Michael Connelly, CEO Emeritus of Mercy Health, the author of The Journey's End, subtitled The Investigation of Death and Dying in Modern America. Michael, you alluded to a little bit before this issue of control. And is this a particular American phenomenon, this patient autonomy and personal autonomy seems to be like ingrained into the American DNA? How much of this gets in the way of really human treatment? I want this, I want that, as opposed to saying, this is what's happening.
So it is a problem, but I think the bigger problem is that you don't know what you're getting. And so you might ask for it, but you don't understand what it is. And there's a lot of research that has shown that when a patient is informed about what a lot of their treatments are, they choose not to have them. So there's a Dr. Angelo Valandez at Harvard that has an institute that's devoted itself specifically to this issue. And he's done research that shows that if you just ask a patient whether they want treatment for whatever the crisis is, 90% of the time they say, yes, I want to get, the curative treatment, even though it might have limited possibility. And then he shows them a video of what the treatment and what their life is going to look like with the treatment. They flip 100% the other direction, and they go to only 10% want to continue with the treatment. 90% do not. And so that caused him to develop videos on all different end-of-life care situations. If this could be on the internet, it would be a wonderful thing to educate people about making informed. Do I want to go on dialysis? Do I want to go on a lung machine? Do I want a feeding tube? You don't know what you're saying yes to, but after you watch the video, you do know what you're saying yes to. The problem is, and I kind of, this is my personal opinion, Dr. Valandez's wife is an attorney, and he's convinced, I think, by her that he would be liable if he gave these videos out to the public. And so the only way he distributes the video is to a doctor's office. And he goes around the country trying to get doctors' offices to have these videos. Well, it's a total bust because no doctors are interested in having videos to say you shouldn't get treatment. and so, but it's very sad. There's also a major project done at a system called the Gunderson Health System, which used videos and used nurses and social workers to help patients complete their advanced directives.
Right. It's out of Minnesota.
It's out of Wisconsin. It's Eau Claire, Wisconsin. And they got 95% of the population in that health system to use advanced directives. And everybody was very happy with the care. And the economics didn't work for anybody else because they happen to have a health plan that helped fund the use of the people to do all that work.
Right. It's a closed system.
And the other healthcare doesn't have it. So it doesn't get spread across America because they aren't in closed systems.
So you raised a couple of interesting points I want to ask you about. Number one, and there was another AARP thing that came out about a month or so ago about another survey. Talk to me a little bit about the inequality of access to healthcare vis-a-vis socioeconomic conditions, locations, racism. That's a reality still, is it? Well, it is a reality, correct?
Yes.
And how in God's name do you begin to overcome that right now in the way we're structured?
So again, it's an education issue, and people don't understand what they're wanting, and so it's particularly significant in the Hispanic and Black population. The Black population, because of the sort of the history of the Tuskegee research, the last thing they want is some white person telling them they don't need health care. More treatment isn't a good thing. They're absolutely going to believe that more care is better care. And so they're coping with that sort of historical concern about their care. And so they are much lower users, for example, of hospice than any other race. The other is the healthcare system isn't designed to recommend this care. And so the only way it does get used is by more knowledgeable people that are familiar with it and ask for it. And so that's another reason that's one of the reasons I wrote the book. It's an opportunity to educate everyone. Right now, if you want to die at home, you got to do a lot of things to make that happen on your own, because the health system will not let you die at home. You'll be going in the ER, and then you're going to go from the ER to the ICU, and then you're going to die in ICU. You have to know how to stop that from happening. And that's some of the thing I talk about in the book.
Yeah, you allude to something else I want to ask you too. It's the middle of June. There was a rather interesting and somewhat disturbing article in the New York Times Sunday magazine, exactly on some of the issues that you're talking about in the book. And the article really put a spotlight on I guess if I can use the term, the corporatization of American delivery of healthcare in the United States of America, where, quote, it prioritizes profits over patient care. It prioritizes profits over patient care. How true is that?
Well, I think it has a misdiagnosis, and it really is the codization, if there is such a word, of healthcare.
What does that mean? What does that mean?
Right now, you can't get paid for anything in healthcare without it being coded. And the coding system is unable to appreciate what's referred to as cognitive care or non-procedural care. In other words, a conversation. So doctors are no longer paid to talk to their patients. They're no longer paid to talk to one another. And if they want to make a living, they have to minimize their conversations. They have to just do things, order tests, analyze tests, do procedures. That's the only way they can make an income. And the specialties that are most dependent on cognitive care are all of primary care. So your internist, your family practitioner, your palliative care doctor, even your hospitalist, they depend most significantly on getting to know you as a patient, talking with you. This is why concierge medicine has become so popular. Patients knew they weren't able to talk to their doctors, so doctors were frustrated and they started their own concierge practices. But the problem with that model is that it's like 1% of the population can afford it. Actually, all of America should have concierge medicine. And so this coding system is also very, very complex. And it's so complex that health systems and doctors don't know how to do their own coding. And 10 years ago, there was no industry called revenue cycle management. Now there's a whole industry that comes into your practice or your hospital and does your billing because they know how to do the coding. How big is that? Last year, U.S. healthcare spent $140 billion on revenue cycle services. As a point of reference, the entire U.S. auto industry is $100 billion. And that doesn't count all the money they're spending on their own billing systems. So, and then the last point with that is that complexity encourages fraud. And so it's easy to manipulate. You can say, oh, I didn't know that, or it was too complicated. And so it's better to manipulate it and then defend yourself. And that's where the profit thing comes in. People take advantage of that. So basically, the way we pay for healthcare is the problem. And that encourages, it isn't like these people don't want to care for you. It's like they want to care for you, but the payment system won't let them. And that's why they're depressed. Right now, doctors spend 47% of their time coding and administrative work and 29% of their time seeing patients. That's why they're depressed. That's why they're leaving.
Right.
Same thing with nurses.
Right.
And so it is, but nobody knows that the cause of this problem is coding. And then coding is the one that, makes it easy to manipulate the system for profit.
So is the single payer system the great panacea that people talk about?
No, because it doesn't. Medicare uses coding. Medicare helped invent coding. So if you don't fix coding, you won't fix anything. It is the way we pay for it. And so Medicare is as bad as anybody with coding.
So and as we wrap up, because we're going to run out of time, you've outlined this here and in the book, this complexity. So what advice do you give us? How do we get out of this mess, Michael?
Well, I think that the first is that you need to take more control of your own healthcare. And you need to educate yourself about what you want in end of life. And it's not that hard to self-teach yourself a number of these things. Second is it's important who your doctors in hospital and your hospice are. You need to get people you trust and people that will talk to you, and that are interested in your preferences of care. And you need to be assertive about that. You need to bring up your advanced directives for the last, when you've hit that point where you think, all right, I got 5 or 10 years left. You need to be bringing that stuff up whenever you're meeting with your doctor.
And to make sure that everybody that, this is part of the stuff that we teach, that everybody you would have in contact with has copies of that. Not only your doctor, your clergy, family. So, cause you never know, we just don't know when you'll need to access that. And so, The worst thing is I've talked to people and they'll say, yes, I put my advance directive in the safe deposit box. I say, well, that's meaningless, because God forbid you're alone, you need it. How are they going to get it?
So yes, getting it in your electronic record, but unfortunately in the electronic record, it's buried. And so, I've actually tested my primary care doctor and said, could you please pull up my advance directive? They can't find it.
So talk to me very fast before we conclude about the advisability, because we're seeing a lot of this now, and the necessity of the PULSE form, the POLST, the physician's order for life-sustaining treatment.
That's a wonderful adjunct to an advance directive, but it's fairly esoteric. I mean, one thing everybody can do that's fairly simple is spend some time thinking about how they want to be cared for and videotaping it on their phone. And so then rather than having to find this advance directive, you just pull up that video from the patient, because you're going to be out of it when this is going on. And so, but if your caregiver has it, they can say, look, no, they don't want any of this stuff. Here's the video to prove it.
So, Michael Connelly, the author of The Journey's End, an investigation of death and dying in modern America. Thank you very, very much. Good luck with the book.
Well, thank you.
Thank you very much for joining us today on today's edition of Seekers of Meaning. And lots to think about, lots to contemplate, lots of work for us to take care of, Michael. So thank you.
Well, you'll have a happier end of life if you pay attention.
No, this is true. To all of you, thank you as well for joining us and the pleasure and of your time today. We really are very, very grateful for your time. Again, if you'd like to make a comment, a suggestion about Seekers of Meaning shows or ideas, email me, rabbiaddress@jewishsacredaging.com. If you'd like to support the work that we do and continue the work for these podcasts and the website, just go to the website, jewishsacredaging.com, go down to the conveniently located donate button and just follow the prompts. And if you'd like to become a sponsor to these podcasts, just also email me at rabbiaddress@jewishsacredaging.com. Seekers of Meaning is produced at the Broadcast Center of Lebeck Media Companies in Cherry Hill, New Jersey. And as usual, a shout out to our producer, Steve Lubetkin. Thank you very much for joining us. Until the next time we meet on Seekers of Meaning, take care, everyone. Stay safe, stay healthy, and most of all, be kind to one another. Thank you very much. Shalom.